talk. Now let me invite our Chief Instructor, Dr. Samyukta Sadasivan, to talk to us on evaluation and diagnostic workup of non-strabismic binocular vision anomalies. Over to you, Dr. Samyukta.
Good morning, one and all. With due reverence to all our mentors, I start off with evaluation and diagnostic workup of non-strabismic binocular vision anomalies. So the two limbs of binocular vision assessment are accommodation and vergence testing. We begin with vision and accurate refraction, followed by binocular balancing, and then we proceed to the proper orthoptic assessment, under which we include accommodative procedures, vergence procedures, and oculomotor procedures. So visual acuity, uniocular and binocular, both for distance and near, need to be assessed as we get clues to whatever we are dealing with from this first stage itself. These are the refraction procedures and binocular testing, binocular balancing methods, Borish delayed testing, sudden unfogging, dynamic and cycloplegic refraction. Orthoptic assessment, we start off with accommodative procedures. Near point of accommodation, or NPA, refers to the closest point at which represents the limit of accommodation at near. This represents the maximum amount of accommodation that the eyes can exert monocularly and binocularly. So as you see, the patient's attention is directed to the row of letters better than the best corrected visual acuity on the RAF rule. He is instructed to keep the letters clear. And the chart is moved closer and the patient is asked to report when the letters become blurred. The distance from the chart to the patient's spectacle frame plane in centimeters is the measured NPA, which can be directly read off from the RAF rule. Now this linear distance, when converted to diopters, will give you the amplitude of accommodation. So these are the average expected amplitudes, Hofstadter's minimum, average and maximum with regard to age. Now we go ahead with accommodative response, which is the assessment of accommodative status during near visual activities, based on the assumption that at a distance of 40 centimeters, the accommodative demand is 2.5 diopters. If the eyes accommodate less than the demand, you call it lag of accommodation, and the opposite is lead of accommodation. So we perform this monocular method of retinoscopy to assess your accommodative response. Patient wears her spectacle correction, best corrected spectacle correction for both near and distance, and the test is performed under binocular viewing conditions. She is instructed to focus at a smallest row of letters read easily at a working distance of 40 centimeters, and now you perform your retinoscopy. Utilize the reflex. If it is a with motion, you add plus lenses. If it is an against motion, you add minus lenses. And the lens power which is required to attain neutrality is noted. The normal expected accommodative response is a lag of accommodation at near of about 0.25 to plus 0.75 diopters. Then you have the relative accommodative accommodation measurements, which is an estimate of the range of accommodation from stimulus to relaxation at a fixed distance. Addition of plus lenses in negative relative accommodation relaxes accommodation. So this will stimulate divergence due to the AC by A cross link. To maintain clear single binocular vision, now the eyes must converge. So inadequate fusional convergence can reduce the end point of negative relative accommodation. Vice versa, in addition of minus lenses when you calculate positive relative accommodation. This is the NRA-PRA testing procedure. Patient wears the habitual correction. N6 target at 40 centimeters is focused at. And plus lenses are added binocularly in plus 0.25 dSPR steps till the patient reports the first instance of sustained blur. That is the value of negative relative accommodation. Same procedure repeated with negative lenses. The first persistent blur is the positive relative accommodation. These are the normal values for NRA-PRA normal accommodative response. For assessing the dynamics of accommodation, you have to do the accommodative facility testing using accommodative flippers. So this is performed using 2 diopter lens flipper, which the patient holds close to the eyes, plus lens first, and on clearing the target, it is flipped to the minus side. The number of flips made are noted. This is a testing procedure and these are the targets given. Patient again wears the habitual correction, standard testing with 2 diopter accommodative flippers at 40 centimeter testing distance. A full cycle includes both plus and minus lenses. Number of flips made per minute is recorded. Now we move on to the Vergence procedures. So we do Fourier measurements, and this is followed by Vergence amplitude assessment, and then Vergence flippers are used to test the Vergence facility. So near point of convergence, the test measures the patient's ability to converge the eyes while maintaining fusion. The patient maintains habitual correction, and the accommodative target is held at 50 centimeters distance on the graph rule. The target is moved closer, observing the patient's eyes until the patient reports doubling of the target, and the examiner should observe for any loss of fixation in one eye. The distance at which the target doubles is the break point. At that time, you receive the target a little backwards, and the distance at which the patient's deviated eye regains fixation is noted. So that is the recovery point. Normal NPC is 8 centimeters. So for fusional Vergence range assessment, we make use of the step Vergence method and the jump Vergence method. Measures the patient's amplitude of fusional Vergence for both distance and near. So step Vergence is assessed using the prism bar. A vertical target is shown at near and at 6 meter distance. Prism bar is placed in front of one eye, base in first, and negative fusional Vergence is tested first. Blur is when the target is not clear, break when the target doubles, and recovery when the target becomes single. All the values are recorded in prism diopters. Fusional Vergence examination, please remember the order of examination: measure heterophoria first, followed by divergence amplitudes, and then we move on to convergence amplitudes assessment. Jump Vergence, we have the Vergence flipper which tests the dynamics of Vergence. Habitual correction is worn, testing distance of 40 centimeters. Standard flippers, 12 prism diopter base out and 3 prism diopter base in are used. The patient is instructed to hold the flipper close to the eyes, base in first, and flip is made when the print becomes single and clear. The number of flips made per minute is noted. So these are the normal values which we expect at the end of our evaluation. This should be followed by ocular motor testing, because children with reading difficulties can have poor saccades and pursuits as well. Do not forget AC by A ratio. The routinely employed method is lens gradient method, where deviation without lens minus deviation with the lens divided by lens power in diopters. So these are the potential components of the diagnostic evaluation for accommodative and Vergence dysfunction. Thank you very much.
Thank you, Dr. Samyukta, for the